Welcome everybody to our 6th webinar on COVID-19 responses. Today we are focusing on Nordic countries. My name is Dimitra Pantelli. I am a program manager with the European Observatory on Health Systems and Policies, and it is my pleasure to introduce our webinar today on this very, very interesting group of countries with a star cast from all the different health systems. And we're going to look at the different way Nordic countries have responded to the COVID-19 pandemic. So we know that health and welfare systems in the Nordic countries, in Denmark, Sweden, Norway, and Iceland, and Finland, have many similarities, have a lot in common. They have also important differences. And we see quite a bit of a difference in their responses to the COVID-19 pandemic in terms of different measures introduced for communication, for contact tracing, for isolation, for distancing measures. But we also see differences in outcomes. So we see different epidemiological trajectories. We see differences in the groups affected, and also in the expected outcomes at an economic level. So we get to talk about that with a really distinguished group of people today. We will hear from Karsten Vrangbæk from the University of Copenhagen, who will give us the keynote speech on an overview over the Nordic countries. And then we have 3 spotlight speakers, or I'd rather say 2 spotlight speakers and a discussant from different Nordic countries. We have Liina-Kaisa from Tampere University. We have Nils Janlöf from the Swedish Agency for Health and Care Services Analysis. And we have Ingrid Sones from the Norwegian Public Health Institute. So with our group, we will first hear from all of them on their perspective, and then we have the opportunity to discuss following what we hear and what you also as our participants know, and we will be very happy to hear from you with your questions and comments. To do that, you can use, as always, during our webinars, the chat function that you see at the bottom of your screen. Please use it to send your comments and to send your questions. At the end of all the presentations, we will then look at what we have and discuss with our panelists. I would like to ask you at this point to address your questions specifically if they are meant for a specific panelist, or just give us your general comments and general questions, which we then will pass to the group as appropriate. The way the session is structured is first Erika Richardson, colleague at the Observatory, will give us a short introduction on the HSRM initiative, which is the background of this work. And then we will hear from all our speakers before we go into the Q&A. I think I stop here for now because we want to have as much time as possible to hear from our experts, and I pass to Erika for a short introduction of the background of the HSRM. Thank you, Erika.
Hello, everyone. Thank you for coming. First thing to say is that the COVID-19 Health System Response Monitor is a collaboration. It's a collaboration between the World Health Organization Regional Office for Europe, the European Commission, and the European Observatory on Health Systems and Policies. And what it does is it organizes and shares information in 4 key areas. Firstly, it's focused on country information, so collecting, organizing, checking, and updating country information on almost 50 countries right across the European region. But we also support comparison across countries, setting it all in context. But you as a user can go in and select countries and select particular areas of the response you're interested in, draw the information all together in one single PDF document. It also guides users to the most reliable international COVID-19 data by offering all the links in one place. So links to the key websites that track the numbers, and also to articles on wider public health initiatives and good practices. Fourthly, we also analyze the key themes across countries. So providing snapshots of different policy responses and setting these initiatives in context. And that's very much the foundation for the work that we'll be presenting today. So this kind of cross-country analysis is also a part of the HSRM. There's a whole section that pulls out the narrative threads. So it picks on things which are interesting, things which are topical, but also things that are important. Now, these cross-cutting analyses are done in response to questions which come up from WHO or the European Commission, or from individual countries, or from the editors themselves who are all working on this project, where we spot emerging issues and pick up on patterns and trends. We like to use this space to give examples of good practices, but also link to key documents. And this section is updated as policy, practice, and indeed the pandemic evolve. So thank you very much for your attention. A lot of this cross-cutting analysis is going to be, has already been published in our most recent EuroHealth. Please do go online to look at some of the articles that have been published on that, but also a forthcoming issue of Health Policy, one of the papers for which is basically being presented today. Thank you.
Thank you very much, Erica. And perhaps it's a good point here to point out that, you know, this cross-cutting analysis that we are doing, especially for the upcoming health policy issue, is structured either with a thematic focus or around a grouping of countries with similarities, where we try to understand how different health systems have reacted to the COVID-19 pandemic in different or similar ways. And one of these groupings are the Nordic countries. And this is also the focus of our webinar today. So at this point, I'm very happy to introduce our keynote speaker for today. So Karsten Vrangbæk from the University of Copenhagen, who will give us an overview of the similarities and differences and help us understand how the COVID-19 response was shaped in Nordic countries. Thank you, Karsten. You have the floor. Please share your screen.
All right, so the screen should be shared by now. And thanks a lot to Dimi and Erica for introducing the event here, and also for organizing the work, both with the seminar series and to the observatory for organizing this collection of very important data on policy responses to COVID-19. So what I'm going to be doing now is provide a short introduction to health policy responses in the Nordic region, and some of the differences, both in terms of policy choices and in terms of outcomes. So more specifically, we'll start with the question of why is it that we in these very or rather similar systems see different results and also different choices in terms of the policy instruments. So three main themes: policy strategies, instruments, and timing, as the first sort of set of potential explanatory factors for figuring out why we see these differences. Then moving on to the broader legal frameworks and governance structures, as they tend to determine some of the policy strategies and instruments and possibilities in making choices. And then we must realize that there's a lot we do not know yet. So we have a group of residual explanations, context and circumstance that might explain also some of the differences. So the well-known known unknowns and unknown unknowns. So let's move on immediately to look at a chart representing some of the trends in the Nordic countries. And really the take-home message from the chart is that if you look at Sweden, it appears to be somewhat of an outlier particularly in terms of deaths, and also in terms of confirmed cases. Now, it should be remembered that Sweden is larger than the other Nordic countries, so about twice the number of inhabitants compared to Norway and Denmark and Finland. So that, of course, is reflected in the confirmed cases. But nevertheless, we see that it's a significantly higher number. And if you look at deaths compared to 1,000 inhabitants, you also see that that Sweden is ahead, so to speak. So why might that be? In our paper, we try to go through different sort of levels of possible explanations. And the first element to look at could be policy strategies and differences in policy strategies across the countries. We do observe, though, that there are a lot of commonalities. So in all 5 countries, there's been an emphasis on protecting vulnerable population groups. There's been an emphasis on maintaining capacity in hospitals, and also an emphasis on keeping societies open as much as possible. So you'll see later that in none of the countries have we used curfews as instruments, and that's partly a reflection of this underlying sort of strategy principle. Then comes some differences. If you look at Denmark, Norway, Finland, Iceland, I think it's fair to characterize the approach as somewhat cautionary. So with politicians taking responsibility early on, and also a willingness to accept the uncertainties and the costs of early interventions. So reactions have been faster than in the Swedish case, and also more extensive than in the Swedish case. So early reactions and a cautionary approach, and then gradually moving on to a more flexible response, which is sort of in line with this metaphor of dance and hammer. So flexible in the sense that local outbreaks or regional outbreaks are being addressed with specific measures. Now, what does it look like in Sweden? There's been a lot of emphasis on stability and sustainability of the policy measures. Bureaucrats and experts have been in a more prominent role than the politicians in the other 4 countries, and the strategies has largely been expert or based on recommendations rather than legal measures. And then finally, this somewhat contested issue that it appears that public health authorities in Sweden have been operating with an idea of potentially reaching herd immunity as a strategy. It's contested because it's not sort of openly admitted to, but you can find documents that sort of explain that at various points in time they have operated with that idea. What's happened in Sweden, though, in recent months is a gradual shift to something that's more resembling the other countries, so like a more flexible dance and hammer type strategy, and more intervention from the political side, the central political side. So it remains to be seen what comes out of that. If we take a more detailed look at some of the interventions that have been applied in the 5 countries, we have developed this chart, and there are two slides showing this chart of policy interventions. And what has to be noted here is that if you look at things in brackets, they would be temporary and they would be partial, so not necessarily for all of the country. If you look at things in bold, these are things that are mandated by law. So the marks in bold are mandated by law. And what's not in bold would be based on recommendations. So what immediately stands out on this chart, which deals with mobility and travel restrictions, is that a lot of the measures have been temporary. And you also see that the countries of Finland, Iceland, Norway, Denmark have been applying legally based measures more than Sweden, which in general has been less restrictive in terms of travel. And as I pointed out before, no use of curfew or restrictions in mobility outside of home in the Nordic countries, but some temporary recommendations or restrictions on travel across municipal and regional borders. So looking at the second chart, so it's the same way of denominating the measures, temporary, mandated by law, or based on recommendation. And again, we see a lot of temporary measures. So, for instance, closing of kindergartens and nurseries in Denmark and Norway, both mandated by law and both temporary. Whereas the other countries have chosen not to do this based on a principle or based on the observation that the spread of the disease is not very prominent through this age group. And also based on the idea that it can keep society open as much as possible if parents can go to work as when kids are in nurseries and kindergartens. What we can otherwise observe here again is that Sweden stands out with more reliance on recommendations and with less restrictions in terms of closing or restricting access to things like restaurants and bars, retail shops, sports facilities, and cultural events, etc. Also, in terms of the number of persons gathered, the maximum number of persons gathered, which is recommended in Sweden and which is stipulated by law in, for instance, Denmark and Norway. So you see here again a picture of more restrictive measures in the 4 other countries and less restrictive in Sweden. It should be noted that these 2 charts cover the spring, so it's in the period from March until August. Of course, things have changed a lot, hence the many sort of temporary measures, and certainly things have changed in the fall, where the pandemic has increased again in all of the countries. So new measures being introduced, but I think this provides a quite comprehensive picture of some of the early measures, at least, and it certainly shows the difference between the countries. So some of the differences can be explained by looking at the underlying governance structure and legal framework. So that this chart shows or provides an overview, and the most important points are highlighted in red, namely that in the Swedish case, the sort of legal basis for intervention comes a bit later than in the other countries. Sweden does not have the possibility to instate emergency powers, and even in terms of the Epidemic Act, the revision of that is giving less discretionary power to the government as vis-a-vis the parliament in Sweden. So again, you have some differences, but looking across the region, you see quite quick reactions to get the legal framework in place, and thus provide possibilities for moving forward with reactions. So a few governance dilemmas which characterize all countries here, and indeed many European countries. So the first one would be between agencies and experts and politics, where you can see that all of the health agencies basically operate in a sort of difficult position between politics and professional autonomy. And what characterizes the situation in the Nordic countries is quite a high level of autonomy to the agencies, and this is particularly the case in Sweden, where also a lot of strategic power has been awarded to the public health agency and experts there. This, of course, can be said to be politically convenient in a sense. It's also potentially very transparent and stable in the sense that you can sort of put forward the background for your decisions from a very sort of professional argumentation. But it also perhaps has an inherent risk of over-reliance on specific professional interpretations and value judgments. That's a point for discussion anyway. Another dilemma is between speed and inclusion and transparency. So speed in terms of reacting quickly to new contingencies versus taking the time to include all relevant stakeholders and creating a transparent decision-making process. And again, here we see slight nuances across the countries, with Denmark, Norway, and Finland emphasizing government capacity to provide fast and flexible responses, but that has in all 3 countries implied also sometimes critique for lack of transparency and lack of inclusion of opposition politicians. And currently, actually, we have a somewhat of an issue in Denmark, which deals with the government acting too quickly and perhaps not with proper legal basis for their actions. So moving on to the the next slide, it's just opens up a debate on another governance dilemma, which is between how many resources we invest in COVID-19 and what the implications are for other public health and societal aims. And this is just one way of starting that discussion, which is by looking at the projections for growth figures in different countries, where you can see that in all countries this has slowed down the growth. So investment in this particular pandemic means that there are other things we cannot do. Now, is it the case that the Swedish measures have created a situation with a better economic outlook than in the other countries? Looking at this chart, it doesn't appear so. But of course, these measures are very uncertain at this point in time. So it takes a while before we realize whether or not the approach taken in Sweden was actually beneficial compared to the other countries. Another way of looking at it would be through unemployment. We see Sweden and Finland a bit higher than the other Nordic countries. So again, no sort of significant benefit from the more open and less restrictive response in Sweden in terms of unemployment figures. And these are just two examples. Of course, we could go much more into depth with discussing the consequences for other patient groups than COVID-19 patients, and deferring some treatments and deferring access to healthcare systems. It's not a big problem in the Nordic region, but nevertheless, over time, I'm sure there will be ramifications. And that brings me to the last slide, which is summing up. We can identify that there are differences in strategy, policy measures, and timing, and that they are likely contributors to diverging results across the countries in the region. However, there are also a number of sort of caveats and circumstances that should be taken into account. So it's worth noting that this is a high trust and high compliance type region, which means that recommendations in the Swedish case work almost as well as legal measures in the other countries. So that should be kept in mind. It should also be kept in mind that the high mortality in Sweden was a lot driven by nursing homes in the beginning, and there are particular circumstances around that, very diverse governance and quality due to municipal autonomy. So the decentralization has downsides in this case. Swedish epidemic also started in high density area with a significant immigrant population, which unfortunately is also overrepresented in some of the trades and some of the types of employment that is most exposed to the epidemic. And then the final point, that we see a gradual convergence of strategies now in the 5 countries. So Sweden is moving more towards strict, harder restrictions than previously, in response to new rise in both death figures and infection rates. So final points, we still have a lot of important unknowns that we're facing. What are the broader health and societal costs, and what are the long-term effects of these interventions against COVID-19? And that brings me to the conclusion. Thanks.
Thank you very much, Karsten. That was illuminating, and I think a lot of food for thought. I think we have this very interesting area that you closed with, this dynamic change in policy and the lack of certainty, of course, now when it comes to the outcomes, because we still need time for them to unfold and we need time to understand them. And I think we'll get back to that definitely in the discussion. For now, I would like, in the interest of time, to pass the floor directly to Liina-Kaisa, to give us a spotlight on Finland and perhaps react to Karsten's presentation. Liina.
Thank you, Dimi, and thank you, Karsten, for this great overview to the Nordic countries. Now zooming a bit further to the Finnish response, Finland has attracted a lot of attention also internationally, because it has, among some other Nordic countries, been quite successful in terms of keeping the infection rates down, and also keeping the death rates down in terms of this COVID-19 pandemic. And I was thinking that I will walk you through the journey of the pandemic so far in Finland, or the measures we've taken, and some things that I feel that are important when we consider the Finnish response and also the Nordic response, maybe also in general. As in other countries in the Nordic region, the epidemic started in the turn of February, March, and the response during the spring was characterized by centralized governance and strong political leadership. What was also characteristic to the response was that the action was taken really early on. So harsh measures were taken already when the infection rates were not that high, because we were somewhat lucky in a sense that the epidemic came to Finland a bit later than to some other countries, and we were able to learn the consequences of what will happen if we don't act early enough. It should be also noted that we were in the state of emergency and also activated Emergency Powers Act, but a lot of the restrictions that were done and given were made in the context of normal legislation, and also most of them were recommendations rather than binding orders. So that's also important to notice. But what was critical, I think, in the context of the emergency situation was that we were able to close the capital region, which was actually the epidemic center at the time, and actually most of the other parts of Finland were not affected by the epidemic. So actually we only had epidemic in the capital region, and we were able to limit the spread. Also, what was important, and I think it relates a lot to this political leadership, but also the condition of emergency, was that the population behavior changed dramatically, as also in other Nordic countries. And of course, the Finnish context is quite fruitful sort of for these kinds of physical distancing actions. We are able to work remotely, many of us. We were quite successful in moving to remote teaching, and also we are a sparsely populated country. What was also important was that during the spring, during the lockdown, and also during the summer when the epidemic was sort of sleeping, we did use the time to build up testing and tracing capacity. And that has that's been the cornerstone of the response in the autumn. So in contrast to the spring, when we were relying a lot to centralized governance and political leadership, the autumn response in the autumn has been characterized by this dance and hammer thing, and local action and also more expert-driven action. In a sense that local authorities have been the key in implementing the testing and tracing system, and they have done it quite successfully, even though we have had the epidemic also now in other parts of the country, not only in capital region. The local authorities have been quite successful in also limiting the spread. But again, the capital region does play a crucial role in terms of the epidemic. And now it's really interesting to see what will happen the coming days, because now we see that the epidemic is getting worse rapidly, and we see, for instance, that the number of hospitalizations are starting to grow. And actually, the capital region is now this morning they have announced that they will go to at least a partially comprehensive lockdown in a sense. So it may be that we are moving again to more centralized response and more politically led response in contrast to the decentralized action. But that was all I had to say at this point. Thank you.
This is wonderful. Thank you. It's very, very interesting. And also thank you for keeping in time. I think this theme of centralization and decentralization is also seen in other countries, and we get back to that for sure in the discussion later. Thank you, Liina-Kaisa. Let's now go to Nils and to Sweden.
Yeah, thank you very much for earlier speakers and the opportunity to give a quick overview of the Swedish pandemic response. And I start with some points of overall strategy and principles. So this has been to contain this virus in the society and keep the healthcare needs within the capacity of the healthcare sector, and protect those at high risk, the elderly, and those with underlying diseases. And the measures taken should also be sustainable over time and adapted to the development. And an important aspect is the crisis management rests on the principle of authority. So the same governance structures that applies in normal times should also be applied in the times of a crisis. And in Sweden, we also has a long tradition of self-governance and a decentralized health care and elderly care system, and this applies also to the infectious control disease management. So I go further to discuss some important characteristics of the policy response. And as Karsten mentioned, this relied heavily on the public health agency and their chief epidemiologist. And this is based on a long tradition in Sweden and the legal framework. And this agency is also responsible for applying the legislation on infection control. And the government motive for this has been then to secure an expert and evidence-based approach. Another important aspect in the policy response is the existing legal framework. And we had no pandemic act in place at the start of the pandemic, so we could not take any more lockdown-like measures. And we couldn't impose a state of emergency and a curfew and so on. So it's unconstitutional to close shopping malls, restaurants and bars, or to impose legal enforceable travel restrictions. So instead, new legislation was needed. So there was temporary legislation empowering the government to take some of these measures, but they were not really used in this regard. And we also have a new pandemic act under investigation, and we plan to be implemented in the summer of 2021. So I continue. So yes, the Swedish policy response is much based on recommendations, even though the law contains far-reaching measures, including locking people up and control if this infection is classified as dangerous. But the important thing is built around voluntary actions and collaborations. So the main thing in the Swedish response has been based on recommendations on physical distancing, working from home, avoiding unnecessary travels, and so forth, and especially protect those vulnerable groups and the elderly. Another important aspect is that the public health agency in Sweden has a very broad mission, so they should look at both the direct health consequences of COVID-19 and also the overall consequences on public health. So they have to weigh this together. And as I mentioned, we have a very highly decentralized structure. So we have 21 self-governed regions responsible for healthcare delivery and 290 municipalities responsible for the elderly care sector. And we also have this in the infection controls side. So we have 21 different pandemic plans. So now a little more deep into the measures taken or not taken. So as Karsten mentioned, the daycare centers and primary secondary schools remained open because they were not seen as drivers of infection from the public health agency's side. And we also had a less focus on travel restrictions for the same reason. And we had no national recommendation on face masks because the public health agency has seen a weak evidence base for this, and it could also have a negative impact on physical distancing. And another important aspect is that the recommendation of contact tracing on a national level was abandoned in March due to this societal spread. And we also had limits on gatherings and bans in the elderly care sector. So what has been some explanation of the outcomes in Sweden? Yeah, we have some shortcomings within the elderly care sector. And yeah, we have this theme of low preparedness in terms of protective equipment among the regions and municipalities. We had slow progress in the testing capacity, and the national goal of 100,000 tests was firstly met in August. And we also have continuity problems and some divided problems within the elderly care sector in Sweden. But the good thing was we were very quick to build up this ICU bed capacity and so forth. So some empirical results was we had this widespread of infection within the home and elderly care institutions. And the share of deaths within elderly care are up to date 73%. And also among the elderly, it's above 80-90%. And also this really huge share of the deaths within the region of Stockholm. And this could be explained, but we got it very high in initial exposure of a virus in in Stockholm, and we also had this during the winter holidays in Sweden, so that could be an explanatory factor. And I also want to show that this is just to show the widespread of regional differences within Sweden, where we see Stockholm at the top of the number of deaths per 100,000 inhabitants. So it's a huge variation within Sweden in terms of the outcomes. Thank you.
Thank you very much, Niels. This is it's very interesting to see the breakdown. I'm sure that we will have questions. And back to the discussion point, we move from Sweden to Norway. And for Norway, we have Ingrid Sones, who is normally with the Norwegian Institute of Public Health, but is now sitting in the US, joining us very early in the morning from the East Coast. And Ingrid, you're also the lead author of the comparative paper that's behind this work. So give us a spotlight on the Norwegian response.
Okay, thank you, Dimi, and thank you, Karsten, for giving this presentation today. I thought I should give you the background in Norway, because not only in Norway, because in 2018, NATO had a huge exercise up in Norway, and they used the exercise to test the emergency preparedness of the Norwegian health system, amongst others, the whole emergency preparedness system. And two important lessons was learned. One, we had a complete evaluation of the health system, this tiny report here, telling keepers and leavers for what to do, how to go forward. And also one on pharmaceuticals. How do we ensure that we have access to pharmaceuticals? Because that is a really big point of vulnerability. So the same year, 2018, we had an update of the health preparedness plans for Norway. This was followed the year after, passed the parliament in November 2019, a pandemic preparedness, contingency diseases. How do we deal with that? So less than 8 weeks before we started dealing with the pandemic, we just passed the plan in the parliament. And we also had an updated information to all the municipalities from the Directorate of Civil Preparedness on the legal frameworks, who is responsible for getting in touch with whom at what time. We had at the end, very end of 2019, we had an assessment of the highest risk, highest threats, or most impact threats that might be posed to Norway. In 2019, November, December it came, and it was a pandemic and shortage of the pharmaceuticals. But what did we learn from the emergency preparedness exercise with NATO? We learned that we needed to have really good planning of notification and cross-sector cooperation in crisis. So this overview of how the ministries and central agencies are going to connect and give notification were passed in the summer of 2019. And it was like an update of older information, yeah? Because we have dealt with emergencies all over. I mean, it's always happening at least 100 years. So they introduced something they called the Preparedness Commission, which is a commission put together with representatives from all the big agencies in the healthcare sector, connecting them also to the other sectors. And those go straight down to the healthcare sectors. So we have the regional health authorities, and you have the public health and primary care sectors. And these sectors they are not part of the emergency preparedness commissions, but they are advisors to the commission. So at the end of January, the Norwegian Directorate of Health was given the task and the responsibility from the Ministry of Health and Care Services to deal with the pandemic. And as the National Advisory Institute, the Norwegian Institute of Public Health is also on the board. So this is how governance of the system is set up. And this is the access, this is the information the public gets, not the individual, but for the public. So it's easy, and this has become, they won the prize for best communication in Norway this year because they're open, they are good. What are we doing? Where can we find it? And going for answers. That said, it is nearly impossible to figure out when, where, and what the Commission is discussing. We just know when they're presenting the new tasks going. Enough about Norway. Now back to discussing COVID in the Nordic setting. As Karsten said, we have learned a lot of looking closer on the role of the agencies, the bureaucracy, and the politicians. And it's still important. How do that function in the different countries? We can learn more about that. And as Liina-Kaisa said, it's the centralized, decentralized governance, because all of us have now emergency preparedness commissions, except Sweden. And they work on how do we govern the decentralized system? How do we manage to get everybody in line to do what they want them to do? And as Karsten pointed out, it is a specific challenge, as we saw in Sweden, the governance of the public and the private providers in long-term care, because they are the hardest hit. And they're also the group that's furthest away from the central bureaucracy, to put it that way. I would like to hear more about Karsten and Niels and Liina-Kaisa, because I think we have not discussed a lot about what is the workforce and social security system. And how, because I'm wondering if the sick leave systems we have, is that different for temporary workers?
I think...
have I used my time?
You have used your time, but that was also, it's also a point that came up in the comments, Ingrid, and perhaps this is a nice, I'll give the floor back to you to finish. It's a nice link to asking the first question in the question round. We have to do that. So take maybe like 30 seconds to wrap up, and then we go to the Q&A.
Yeah. And then I just wanted to say that, as Niels pointed out, that contact tracing was given up quite early in Sweden. And it also has been on a voluntary basis more in Denmark, whereas Norway, Finland, and Iceland has had it in place all the time. That might be an important factor. And talking about transparency and governance, I think it's important to remember trust goes two-way, because everybody talking about people trusting the governance, but the governance need to show that they can actually trust the people when they start using legislative measures and being really pressing hard. So, but the thing we have not discussed at all is the access to very good quality data. And I think that has been like the basic, and we just take it for granted in the Nordic countries, I think. So we just act on it, and we know that we can trust the data, but it has been done a lot of work, at least in Norway, to make sure we get even more live reporting. So these are the things I would like to have more about. Thank you.
Wonderful. Thank you very much, Ingrid. I was planning on drawing some general conclusions at the end, but you already did that now with the first 4 points in that slide. So we'll think about something else. I think this is the point where I thank you all again, and we move to the Q&A. I saw in the interim that there were a number of interesting points raised. Erica, I will pass to you to highlight. Go ahead.
Okay, so there's been some really interesting stuff coming up in the chat box. But 3 really good questions to just kick off with. One of them is, to what extent have the Nordic countries actually been cooperating in tackling the pandemic? And that's from Anna-Lena Kirch. And then what about the differences in the economic bailout packages, which links nicely to Ingrid's point. And that was a question from Tina Fisher. And then, has there been difference in the vaccine prioritization groups? There's a question asked by Irina Jakopanits. And I mean, I think we could broaden that out and say, with the vaccine on the horizon, are there any significant differences in the way that countries are trying to integrate, vaccine preparedness into their pandemic response? So, and then I'll do another round, hopefully.
So I can speak to the two first. In terms of cooperation, we looked at that a little bit as part of our group, and what we found is that it seems there's been a lot of sort of sharing of information. So what Ingrid was talking about, all of the countries have fairly good databases and information systems, and there's been sharing of that and discussion of strategies among the agencies, so among the experts. And there's been some discussion among politicians, but it's not as clear. And obviously there are similar policy responses, but they're not coordinated as such. They just tend to be going in the same direction. So in that sense, it's not a clear collaboration. Where there's not been collaboration is that there's not been sharing of resources, and that has to do with the fact that there hasn't been a need for extra capacity in ICU beds, etc., in any of the countries at any point in time. And I think, I mean, there's been some talk about this, but in the end, it's also political decision makers in different countries that have to look out for their populations. So the decision processes have not been fully coordinated in that sense. What has happened, though, is that there's been an early move to more regional assessments in terms of travel restrictions in all countries, and that has implied some degree of sort of discussing cross borders, so opening up for regions that are important for collaboration and so on. So that was the first point. The second, on the economic aid packages. So what we've seen in all of the Nordic region is that sort of a natural response is to fall back on the very corporatist types of approaches. So involving societal partners, unions, industry, and so on in negotiating some of these packages, including some of the sick leave packages that Ingrid was talking about. But otherwise, the needs have been slightly different in the different countries. So shops, bars, event economy has been hit more in Denmark than in Sweden due to the different policies on openness and closeness. So therefore, slightly different focus points. And of course, the big remaining and overarching question is how the export industries in all of the countries will do in the long run, because that's what really determines the economy. And that's sort of outside of the scope of this region. We rely on having export markets in the future as well. And the structure is slightly different in the different countries. So the outlook is also a little bit different across the 5 countries in the region. And that's it.
Thank you, Karsten. Yes. Liina-Kaisa.
Yeah, I just wanted to thank you, Karsten. I think this was a good overview. I just want to add that in terms of cooperation, I think there has been some cooperation also in terms of resources between Finland and Sweden in the sense that I think that in the northern Finland, at least, there has been, the authorities have sort of promised to provide capacity if the capacity will be reached because of the worsening situation in Sweden. But otherwise, I have nothing to add.
Either Nils or Ingrid want to come into these questions. Otherwise, we can move maybe to. I can point out, I think at this point, that you are all working together on a comparative paper. There is a question on this in the chat. We mentioned it here and there, but maybe just again for those who entered late, it will be published. It's not published yet. Some of us are privileged and have seen a draft, but for everybody, it will still be forthcoming. And maybe to reiterate one of the questions that Erica posed, I think the vaccination strategy was not in the scope of the paper yet. Is that correct? I think that's because it started being particularly relevant a little bit later than the core timeline that you're looking at. Yeah. So I think we may have sporadic reactions, but perhaps we put the vaccines question on hold for a future webinar where we have more policy and more information. Erica, back to you.
Okay, so we have some questions which are specific to particular speakers and some which are more broad. One of them, which was asked by Maria Villadiego, was how important do we think the gender of political leaders has been in this, which is something which has been widely discussed in the papers, if anybody wanted to tackle that one. Otherwise, there's a question for Ingrid, which is whether or not she feels the Swedish strategy would be possible in Norway, and would that have had success? But also, there was a question for Karsten about whether or not it was obvious that Sweden had to centralize their national system and get more legal muscles regarding the epidemic situation to be able to respond fast enough in the future. So perhaps that's one for Nils as well. Is this something that will be looked at in 2021 when the new pandemic legislation is being discussed? And then one final really nice question to round up this round would be, what are the criteria that we're measuring success in managing this epidemic on the population level versus evaluation of successful management of public health overall? And how would this be done systematically? Okay, so back over to you. And then if we've got another chance for another round, I'll do it. Okay.
I doubt it, but let's try and see who would like to go first. Perhaps we choose a different sequence this time. Ingrid, please go ahead.
Okay, to the question of whether Sweden could adopt the Norwegian approach, if you're talking about culturally, I think there's no problem of being more common, but I think, as Nils very nicely pointed out, it is legal matters, and so you can't just adopt a strategy. You need to adapt it and to your local context, as Karsten was good to point out in the beginning. There are known unknowns here, and this is what we have to look into. It's this danger of thinking one strategy fits all, and you can just transfer it. But but I think the idea of how to work with it is good. The second question on to Norway, I have this question on the Corona Hotel and what it is, and that people have to cover the expenses for that. What do you think the rule in terms of rights, and do you expect this rule to stick around? I expect the rule to stick around for quite a while, because if you are moving and across countries for work, there are exemptions. Then your employer have to provide different accommodation for you. So it is, you still have the freedom to move, and you can just have, so there are ways around that, but it's quite subsidized. So it's not the most expensive hotel stay you have.
Okay, thank you very much, Ingrid. Maybe if you can maybe weigh in very quickly about the other way around. So whether Norway could adopt the Swedish strategy, because we understood from Nils that Sweden had legal restrictions and couldn't adopt the Norwegian strategy even if they wanted to. But what about the other way around?
If we could adopt the Swedish, yes, but I think we will have the same success as Sweden.
Fair enough. I think this is a very nice way of putting it, leading straight to Nils' comment. Nils.
Yeah, there was this question about the political leadership. I just want to say that's of course very important, but I think the main thing is that you should also, there's a lot of insights from in the policy responses when you look into the institutional and the legalistic settings in the different countries. So that's a main effect that I think the policy responses could also be traced back to that, especially for the Swedish case, I would say. And then there was this question about decentralization and centralization within the Swedish healthcare system. I think this will be a very important subject for the COVID Commission, and there's also a big debate going on this in Sweden. So, and especially they will focus on the shortcomings within the elder care sector. So that's of course very important aspect for the future.
Can I weigh in here, because we're running out of time? Basically, we have 2 minutes left. And I had the privilege of looking at your manuscripts that others haven't had. And I understand that in all countries there are commissions that have been put together in order to evaluate the response, short-term, mid-term. So I think this was the last of the questions that Erica posed from the chat, that there is a systematic evaluation planned, at least in all of the countries that we have represented here, and who will also look at this element of when is it okay to grant exceptional emergency powers and change existing circumstances in situations like the COVID pandemic. So there is a plan for a comprehensive strategic evaluation in all countries. Is that correct? If it's not correct, then please, Karsten, I see you already. You are switching on your microphone. Please go ahead. And maybe, Karsten, also as a keynote speaker, give us a wrapping up sentence, because we have to close the session very soon.
Okay, so it's correct that there's a lot of debate and also commission set down to evaluate some of the process elements and some of these power division issues. But I think that's going to be ongoing, certainly in the Danish setting. That's what we see, a lot of discussions, and it's these triangular governance dilemmas, so between parliament and government, between government and experts, agencies, and so on, and they are perennial, and of course they surface particularly in these kinds of situations. So that would be the response to that. And then for wrapping up, and in terms of how to evaluate the whole intervention or strategy approaches towards COVID, I think there are a lot of sort of COVID-specific measures, of course, and there are some of the ones we've presented. We could add to that the question of long COVID, so the long-term consequences at the individual level for people being affected and so on. So there's a lot specifically related to COVID. But then what I tried to point out was that of course we need to look at the economic consequences, both in terms of what the state can do in the future, so the state capacity to invest in both healthcare and welfare state issues that we all like to do in the Nordic countries, but this certainly has taken a lot of money out of the purse of the states. So, and there are implications of that long term. And then some of that will have an impact on the public health for other groups in society. So mental health, I think, is a big issue with some of the measures that have been imposed here. Healthcare for the elderly, some of them have not been accessing healthcare to the extent that we would like to in this period, and that means that some of the chronic diseases are not being taken care of to the same extent. But that remains to be seen. And then I think more generally, we may face a situation where more tough prioritizations have to be made in the future, also because of the investment on this. So we need to get more knowledge about these sort of derived effects and some kind of system for balancing the investment in one and the other type of intervention.
Thank you very much, Karsten. I think this is a great note to end on. I think we understand the importance of similar but different for the Nordic group, the importance of the legal framework and the governance framework. And I think we could have another webinar and we would still not be done discussing all the important points and the interesting different elements that came up from your contributions, but also from the chat. So let's keep that in mind. And when we work on those elements that we realize we haven't talked about enough, then we reconvene at a later date to highlight them for everybody. For now, I think we wrap up for today. I thank you all very, very much for your contributions. This has been illuminating. I'd like to invite everybody who is here to join us next week as well. Same time, same place. We have primary care and the role of primary care in the COVID-19 pandemic in social health insurance countries, in the group of social health insurance countries. So feel invited and be excited about that topic as well. And remember to fill out the evaluation for this webinar. You will be getting a link in your email soon. Yeah, and have a nice rest of the day everywhere in the Nordic countries, in the US, wherever you're from, joining us today. See you all next week.